Hi there, my name is Kestrel Riopel, and I'm a third-year resident at Maimonides Medical Center in Brooklyn, New York. And today I want to talk to you about a challenge. Last summer, three of my co-residents and I, after identifying that EKG interpretation might be one of the weak points in our residency's current didactic curriculum, we challenged ourselves to create an entire EKG curriculum. Taking it a step further, we challenged ourselves to see if we could bring the brand new EM interns up to the skill level of some of our senior residents just by participating in this curriculum. Pretty lofty, I know. Of course, we all know that rapid and accurate EKG interpretation is one of the most crucial skills that an emergency physician must master during their training. To our knowledge, no study had yet compared EM residents with a dedicated EKG didactic to EM residents who have only had on shift or clinical experience with EKGs. The objective of this study was to compare the proficiency of EKG interpretation between the intervention group, which was our new class of interns, to a control group, the existing residents, who in our residency would have received pretty much all of their knowledge from either reading EKGs on shift or studying independently. Because at this point, our residency did not yet have a formal EKG didactic curriculum. We boldly hypothesized that interns engaging in our novel interactive EKG course would prove just as competent as senior residents who had not. Now, I just want to take a quick moment to explain the design of our curriculum in case you're curious. However, this innovation was already detailed in a workshop at Cord's Academic Assembly, and so it's definitely not the focus of my talk today. The curriculum was novel in that it was completely led by senior residents, and it was presented in real time online, utilizing as many interactive features as possible in order to foster a ton of participation and a lot of discussion. So, not your traditional lecture series. This was a retrospective prospective cohort study comparing performance on a 26 item assessment between the PGY1 cohort, offered the 6 hours of near peer taught EKG didactics, and then the PGY2 through 4 cohort in one single EM residency program. We also compared PGY1 competence both pre and post course in an attempt to establish some curricular validity. The main outcome was median assessment score as a percentage of each cohort. Additional variables included perceived comfort interpreting EKGs, perceived knowledge of EKG rhythms, and perceived comfort activating the cath lab. And each of these was graded on a 5-point Likert scale. And lastly, all of these outcomes were analyzed with a non-parametric t-test. A voluntary convenience sample of 24 PGY 2 through 4 residents did complete the assessment and had a median score of 61.54%. 17 PGY1 residents completed the assessment prior to our didactic course with a median score on the assessment of 53.85%. 14 of these PGY1s were also able to complete the post-course assessment, scoring a median of 57.69%. Pre and post-course comparison among the PGY1 cohort yielded a p-value of 0.224, so not a statistically significant improvement, unfortunately. However, PGY1 subjective comfort interpreting EKGs did significantly improve from a pre-course median score of 2 to a post-course median of 3 on that 5-point Likert scale, and the p-value of 0.002. Their perceived knowledge of EKG rhythms also improved from a median score of 3 with 25th to 75th percentile range of 2 to 3 to a median score of 3 with a percentile range of 3 to 4 and a p-value of 0.014. Lastly, their comfort activating the cath lab also improved from 3 with a percentile of 2 to 3 to a score of 3 with a percentile range of 3 to 4 after the course, which was also statistically significant. So to conclude, PGY1 residents were not as competent interpreting EKGs as the PGY2 through 4s, even after the novel didactic course. They did, however, gain a significant perceived improvement in their comfort interpreting EKGs, their knowledge of EKG rhythms, and their comfort identifying a STEMI. Course validity was called into question, given the insignificant improvement of competency of the PGY1 cohort pre and post course. However, this lack of improvement could have also been due to a poor assessment tool, which in retrospect was a very challenging assessment and not perfectly aligned to the content presented in the interactive Zoom course. Study limitations included a small sample size, optional course participation, optional assessment completion, and once again, the challenge of writing an assessment that would effectively measure the competency of such a wide range of learners. I just want to say thank you for taking the time to hear about my work, and a special thank you to my co-instructors, Duncan, Q, and David, and of course to our faculty advisor, Dr. Lee. Thanks.
Hello, my name is Christian Rosenau. I'm a third-year medical student at the Mayo Clinic Alex School of Medicine in Arizona. I'll be presenting today on resident productivity in the emergency department after our institution implemented an automated patient assignment system. We have no disclosures. Emergency departments, especially those at academic centers, are often resident-driven. This includes emergency medicine residents, as well as non-emergency medicine residents who are rotating in the emergency department. The efficiency of care in these emergency settings hinges upon resident productivity, as these residents, both emergency medicine and non-emergency medicine, are seeing the patient, diagnosing, ordering imaging, medications, and other treatment modalities, as well as putting in admission and discharge orders, seeing through a majority of the process of the patient care. Further, with new duty hours limiting the amount of time residents can spend on shift that are being implemented nationwide, it's important that residents maximize each of their shifts for the advancement of their own education. At our hospital in Phoenix, we have a 27-bed emergency department, which sees approximately 40,000 patients per year. There are no emergency medicine residents. However, internal medicine PGY1 and PGY2 residents, as well as transitional year PGY1s, rotate through the emergency department 1 month at a time. Previously, our residents were asked to self-assign patients at their own pace. But in July of 2020, an automatic assignment system was implemented. This system, which is an algorithm based in our EHR, which we use Epic, follows the following algorithm. It assigns one patient at the start of the resident's shift, an additional patient 30 minutes into the shift, and an additional patient every hour thereafter for the remainder of that shift. We used a de-identified database to calculate resident productivity as measured in patients seen per hour and per shift equivalent, which I'll mention shortly, with the self-assignment as opposed to the automated assignment system. Our study included 28 residents pre-implementation and 14 residents post-implementation of the automated assignment system. Prior to implementation, residents worked on average 11-hour shifts. Following implementation, residents worked 8.5-hour shifts. So when calculating our patients per shift data, this was based on an equivalent to an 8.5-hour shift, using the standard data for residents after implementation and correcting the 11-hour shift data for pre-implementation such that it was proportional to an 8.5-hour shift. We saw a significant increase in both the number of patients seen per hour and the number of patients seen per shift after implementing our automated assignment system. This equated to approximately 1 additional patient seen per shift. This is a graphical demonstration of our data. There was some variance across the data, particularly in the pre-implementation group, as these residents had more laterality to decide their own pace, whereas with the automated assignment system, there was a more standardized mechanism for the number of patients being seen. So to conclude, both patients seen on a per hour and a per shift basis by residents was significantly higher after the implementation of our EHR-based automated assignment system. This increase of approximately 1 patient per shift extrapolated over a 1-month, 18-shift rotation equates to 18 additional patients seen by that resident, meaning 18 additional opportunities for patient interaction, diagnosis, and navigation of the medical record. This extrapolated over the course of 1 year, or even over the course of the entirety of a residency for an emergency medicine resident, equates to hundreds of additional patients seen, providing ample opportunities for improvement of clinical acumen, patients' interaction skills, and skills in navigating the medical record and the hospital system as a whole. The efficiency of care by residents is vital in centers that rely on resident contributions to patient care. Increased patient volumes aid in residents developing care management skills, as well as the acumen that I mentioned briefly before. We hope that this provides a framework for larger studies in centers with dedicated emergency medicine residency programs, so as to further prove the benefit of these automated assignment systems in improving both efficiency and productivity of the residents for their own learning and for the functioning of the hospital itself. And thank you. With that, we'll field questions.
Hi, my name is Casey McKay. I'm a third-year emergency medicine resident at Indiana University, and this is my project on resident perception of moonlighting. I have no financial disclosures for this. So resident moonlighting is the independent practice of residents outside of their place of training. This practice has been somewhat controversial over the years, and some larger organizations such as AAEM or ACEP speak out against resident working independently. Other organizations such as EMRA support moonlighting and this function as a supplement to patient or resident education through our residency. Ultimately, it is allowed by ACGME within certain parameters, such as long as it falls within the 80 hours per week duty hours, if the resident's in good standing, and they are not a PGY1. There have been previous studies into the why of resident moonlighting, but it's been about a decade. Some studies in the 90s and 2000s looked into why residents moonlight and what the ultimate benefit to them was. Many studies cited educational debt as a primary reason for why residents did moonlighting, and one study found that 44% of internal medicine residents that moonlit said that they would not have been able to make basic ends meet without their additional supplemental income from moonlighting. Other surveys found things like educational experience and paying back student debts as primary motivators. At this time, the average amount of educational debt was $40,000 to $70,000, which obviously pales in comparison to the 2019 AAMC average of about $200,000. One study in the year 2000 found that over half of emergency medicine's residents participated in moonlighting, and at that time, 91% of programs did allow it in some capacity. Since then, there's been pretty minimal research about why the residents do moonlighting and what the benefits may be. Obviously, educational training, educational debt has changed a lot over this time, and our goal is to look to see if the main purpose and the main benefit of moonlighting has changed or stayed the same. So what we did was we conducted an anonymous cross-sectional interest-based survey of current residents and graduates of a single center emergency medicine program. We collected demographics, if people moonlighted, and what their perceptions of moonlighting were. And then we used descriptive statistics and chi-square testing to analyze our data. Overall, we had 198 surveys returned, which was a 45% response rate. We found that 4.5% of current residents moonlight and 42.4% of graduates had done moonlighting during their time in residency. The primary motivations for moonlight were additional income 96% of the time, gaining a new positive educational experience 82% of the time, and gaining the experience of working independently 70% of the time. Of those who did do moonlighting during residency or are moonlighting, they found that they had gained improved financial stability 68% of the time, had positive educational experience 74% of the time, gained experience working independently 91% of the time, and also felt that they had an improvement to overall wellness independently from doing their moonlighting 72% of the time. We did not find any statistical difference between educational debt of the current and the past residents, which was somewhat surprising. Looking at the raw data and the graph, the light blue line is the residents, and it does seem like it had favors more heavily towards the right side of the graph and the higher educational debt, but the overall trend was not statistically significant. This may be due to the fact that the graduates were anywhere from 1 year out to 15 years out of residency, which is a pretty wide time frame for what people would have collected as far as their debt goes. We did find that residents with $150,000 or more in debt were statistically more likely to moonlight. We'd also compared things such as if someone has a single income, dual income, how many dependents, if any, they have at home, to see if there was any correlation between that and someone's choice to moonlight, but there was no statistical correlation there. So overall, we found that additional income and the educational experience were the primary motivators for residents to moonlight, and many who did felt that they did achieve these goals. There was an association between larger debt and someone's choice to moonlight, and we did find that there was a pretty significant improvement in wellness of those who did choose to moonlight. The next steps from here, so this was just a single center study, and we want to expand it out to a larger multi-center survey. So what we would do is now send this out to other emergency medicine programs and see if their answers and their reasons for moonlighting and what they found beneficial is similar. Questions?
Hi, I'm Dr. Danielle Miller, and I'm going to present the abstract, The Standardized Letter of Evaluation in Emergency Medicine. Are the qualifications useful? The authors listed have no disclosures. So the Emergency Medicine Standardized Letter of Evaluation has been identified by residency program directors as the leading metric for determining whether to interview an applicant or one of the leading metrics for ranking applicants. And previous research has focused on grades and global assessment portions of the SLO. However, there remains a paucity of literature on the SLO's 7 qualifications for EM section. And within the section, applicants are compared to other applicants on commitment to EM, work ethic, ability to develop a differential and treatment plan, ability to work with a team, ability to communicate, anticipated guidance of the applicant, and prediction of success of the applicant. And in 2014, PDs categorized these qualification questions as good questions. Yet a recent survey raised concern on whether the qualification section actually provides useful information. Additionally, there's no literature evaluating the correlation between the 7 qualification questions and other important aspects of the SLO, such as grades, global assessment, and rank list position, as a means to provide validity evidence for the 7 qualifications. Thus, the aim of this study was to determine the correlation between the 7 qualification questions and grades, global assessment, and rank list position for applicants applying into emergency medicine. This was a multi-institutional study of 3 United States EM residency programs, Rush, University of Florida at Jacksonville, and Stanford during the 2019-2020 application cycle. And all applicants from US LCME and DO granting schools who applied to at least one of these 3 institutions were included in the study. Any duplicates were removed prior to data analysis. And a Spearman correlation coefficient was calculated between each of the 7 qualification scores in the applicant's grades, global assessment, and rank list position scores in a pairwise fashion with statistical significance set at a p of less than 0.05. There were a total of 3,250 applicants that met initial inclusion criteria, and then after excluding overlapping applicants and applicants with no SLOs, there were 2,106 applicants. Additionally, this represents about 61.9% of all EM applicants for the 2019-2020 application cycle. We then analyzed 4,939 SLOs. Demographics are shown in this table, and the gender distribution aligns with current national percentages on students matching into emergency medicine in the United States. And this is the distribution of scores and correlation coefficients of the 7 qualifications for EM. So you can see the 7 qualifications listed on the left and the correlation coefficients for each qualification with grades, global assessment, and rank list position in the last 3 columns on the right. And of the 7 qualification questions, 3 were moderately to strongly correlated with global assessment and rank list position, which is shown here in yellow, including the ability to develop and justify an appropriate differential and treatment plan. How much guidance do you predict the applicant will need during residency, and what is your prediction of success for the applicant? And there was no strong correlation between the 7 qualifications and grades. You can also see in the first 3 columns the distribution of scores for the 7 qualifications, with consistently unequal distributions despite instructions to letter writers to distribute equally into thirds. So when we ask ourselves which of the 7 qualifications are correlated with grades, global assessment, and rank list position, we found only 3 qualifications that were moderately to strongly correlated, and these were just between global assessment and rank list position. Again, these are the 3 qualifications, and they're listed here. And overall, there has been debate in the literature about the value of the 7 qualifications section in the SLO and its use in interview selection and residency ranking. And our study adds to this discussion by providing objective evidence on which qualifications are correlated with important metrics such as global assessment, rank list position, and may offer guidance to residency, interview, and rank selection. Additionally, consistent with other studies, our studies also found that the qualification section had disproportionately high rankings. So when looking at the distribution of scores for the 7 qualifications in our study, less than 10% of SLOs in all 7 categories fell into this lower third category, which limits the ability of programs to adequately interpret this section of the SLO. Thus, the qualification section may benefit from revisions using validated workplace-based assessment scales, including behavioral anchoring descriptions to ensure more consistent rating by evaluators. Lastly, our study found no strong correlation between the qualification and grades. Previous research has reported grade inflation to occur in up to 60% of SLOs, and this likely explains the lack of strong correlation between the qualifications and grades. Overall, our conclusion was there was a moderate to strong correlation between 3 qualifications with global assessment and rank list position, suggesting that these qualifications can provide the most useful data for residency selection. And future studies are needed to evaluate whether modifications of the qualification section questions or augmentation with behaviorally anchored questions would be beneficial. Here are references, and we will open it up to questions.
Hi, I'm Ben Del Bono, and this is Breaking Bad News with Virtual Technology. We declare no conflict of interest. Emergency medicine physicians are frequently faced with the task of delivering bad news, often without adequate training. The SPIKES tool was established to guide healthcare providers to effectively deliver bad news and has proven to enhance these skills among EM physicians. Let's take a closer look at the SPIKES tool. The pre-element was established here at VCU and prompts the provider to think about what they will say in the encounter, to become emotionally ready to deliver sensitive information, to review necessary medical information about the case, and to arrange to include whomever the patient or the family member would like to be present for the conversation. Setting allows for introductions and to ensure the conversation is occurring in a quiet and private environment. Perception is asking the patient or family member what they already know about the situation. Immediate concerns invitation elicits readiness for the conversation amongst the patient or family member. Knowledge involves being clear, concise, and unambiguous with the language you are about to deliver. Empathy encourages the provider to acknowledge and allow for emotions throughout the encounter. And summary, second touch allows for discussing next steps and follow-up beyond the conversation. Bad news in the clinical setting is traditionally delivered in person with an emphasis on privacy. Due to COVID-19 visitor restrictions, breaking bad news through telephone and video communication is a skill that is in need of further guidance and education. Our study aims to evaluate high-fidelity simulation sessions for improving a learner's ability to deliver bad news using telehealth technology. Our study was carried out at an urban 3-year emergency medicine program with 12 incoming emergency medicine interns. The interns received a lecture on the pre-SPIKES framework and then broke into virtual breakout rooms with standardized patients and physician moderators for a simulated encounter. In these virtual breakout rooms, interns received a 5-minute introduction video reviewing telehealth technology. There then was a 10-minute scenario where the intern informed a patient's family member they are suffering from the COVID-19 virus. A 10-minute feedback session then ensued with the standardized patient and physician moderator. Following that, there was a 10-minute large group debrief. This is a flowchart that described the study protocol. The first element was education that consisted of the pre-spikes PowerPoint and video examples. This was followed by the simulated encounter with the standardized patient who acted as a family member of somebody with COVID-19. And finally, the feedback portion that consisted of feedback with the standardized patient, the physician moderator, and the group debrief. Interns were surveyed at the completion of their encounter. Frequency analysis assessed how many interns had previous experience with Breaking Bad News training. Descriptive analysis using Likert scale items measured the participants' overall perception of the structure, execution, and value of these training sessions. 11 of 12 interns participated in the study. 73% had received formal Breaking Bad News training in the past. 64% had actually delivered bad news to a patient in a clinical setting. Only 10%, however, had ever delivered bad news remotely, and 27% had formal training on delivering bad news remotely. All of the interns either agreed or strongly agreed this was a valuable learning experience, and feedback would help to improve their communication and practice. The majority also felt adequately prepared to deliver bad news remotely. Most either agreed or strongly agreed they felt comfortable communicating with the patient using telehealth, and that they could easily talk to the patient using telehealth. Most either agreed or strongly agreed they would use telehealth again to deliver bad news, and they were satisfied using it to deliver bad news to patients and family members. Our study has implemented a training program for EM physicians on how to utilize the spikes methodology in breaking bad news with the adaptation of telehealth. The majority of our learners found this to be an effective method. Future studies would be beneficial in assessing the impact of using telehealth in a real-life scenario. More research is also needed to assess if our approach is generalizable across other medical specialties. Limitations of our study include that it was conducted at a single site with only emergency medicine interns. Outcomes are subjective levels of Kirkpatrick and will need to be confirmed by observational assessment methods. Scenarios were conducted with standardized patients rather than a real patient or family member, thus potentially impacting the learner's overall emotional experience. Thank you for listening to our presentation on Breaking Bad News using virtual technology. I hope you enjoy the rest of the conference.
Hello, my name is Caden Crawford, and I am a third-year emergency medicine resident in Corpus Christi, Texas. The title of my project is Trust of Caregivers, a prospective study of Hispanic versus non-Hispanic emergency department patients. I have no financial or non-financial conflicts to disclose. I'd like to thank my co-authors, Drs. Guardiola, Wallert, Olson, Shu, Torres, and Richmond. By way of introduction, trust affects patient care by improving follow-up, preventative care, compliance, a self-reported ability to manage chronic illness, and patient satisfaction. There has been a decline of trust in the fee-for-service era, largely due to malpractice cases and incidents of abuse of power being more widely publicized. Issues surrounding trust in literature include a paucity of research surrounding how trust in a patient-physician relationship is defined, created, and evaluated, and how ethnicity affects it. A lack of methods exists to evaluate trust in the emergency department setting, and prior to a study by Kelly et al., our literature search did not yield any measurable scale to gauge patient trust in the emergency department. Fasal et al. In 2011 conducted a census from 2000 to 2010 and found that the Hispanic population increased from 35.3 million to 50.5, a 43% growth. And the Hispanic population accounted for 56% of the nation's growth from 2000 to 2010. Kumar et al. In 2009 found that the patient-physician relationship is strengthened when there are perceived similarities in beliefs, values, and communication styles, and race concordance is the primary predictor of perceived ethnic similarity. Despite these facts, our literature review did not reveal any previous studies where trust was specifically measured in terms of different ethnic groups. The primary objective of my study was to evaluate the trust of caregivers in Hispanic and non-Hispanic emergency department patients. The secondary objective was to measure patient satisfaction in the context of patient trust in caregivers. In terms of methods, we did a prospective, observational, cross-sectional study in the setting of an academic urban emergency department. Our population consisted of a convenient sample of adult, consenting, non-incarcerated patients who were alert and oriented from August 2019 to July 2020. At time of disposition, patients completed a structured survey in Spanish or English and indicated their satisfaction on a 0 to 10 VAS scoring system. They also answered an 18-question previously validated trust instrument by Kelly et al. That we will discuss momentarily. Categorical data was analyzed by chi-square, continuous by t-tests and one-way ANOVA. Multivariable logistic regressions were performed to assess the association of patient characteristics with high trust scores and high satisfaction scores, respectively. Let's talk about our results. We enrolled 390 patients, 58% were female, 23% greater than 65 years of age, 64% Hispanic, and 44% less than 20 indicated a gross annual income of less than 20,000 a year. With respect to demographics, only the following were associated with higher mean trust scores: income less than 20,000 and private insurance. There were no significant differences between mean trust scores for Hispanic, non-Hispanic white versus other races. There were no significant differences in bivariate analysis for patient characteristics and mean satisfaction scores. Multivariable regression models revealed Hispanics were not more likely to provide high trust and good satisfaction scores, respectively, and those with county insurance were less likely to provide a high trust score. In terms of discussion, other studies have been done to evaluate trust, not specifically in the emergency department. Hall et al. In 2001 evaluated trust in physicians in general instead of in a specific physician by calling a random phone number database. Leeson et al. Developed a comprehensive bidimensional trust scale specific to physician-patient relationships by utilizing mail-in questionnaires. Rose et al. Measured distrust by surveying prospective jurors in Philadelphia. And Cow et al. Evaluated how choice in physician and length of relationship are related to the development of trust in a primary care office. Kelly et al. In 2005, as previously discussed, validated a questionnaire to measure patient trust in an urban emergency department. It had good face and construct validity, good internal consistency, and high test-retest reliability. It was designed for comprehension by patients with low levels of literacy and designed to avoid skewed responses. Ultimately, an 18-item survey was found to have good internal consistency for direct or telephone interviews. These are the final 18 items. Within our literature review, we did not identify a prior study that sought to utilize or validate the Kelly et al. Instrument, and our study group was significantly different from theirs in that it was predominantly Hispanic, 62.4% to 3.1%. And although we expected to see a difference in trust levels related to ethnicity, no difference was observed. Some limitations of our study include that it was a survey instrument developed in a single urban emergency department among focus groups, which raises the concern for external validity. Our patient population chose to utilize Christus Spawn, which may indicate an underlying greater trust in our hospital, leading to a sampling bias. Our population in Corpus Christi is also predominantly Hispanic, and our results may not be reflective of other cities. Chief complaint and frequency of ED use information was also not collected, and these factors may affect perception of trust and satisfaction. In conclusion, patient scores of caregivers in the emergency department were high, and no association was found between ethnicity and trust scores. Thank you.
Hello, my name is John Cameron, and I will be presenting the study titled "Are Emergency Department Patients with Reported NSAID Allergies Willing to Undergo Allergen Skin Testing?" It should be noted that the study authors were unavailable to present this study. As chief resident of this class, who is also interested in academics, I volunteered to present this information with the author's consent. Authors are seen here. We have no financial or non-financial disclosures to discuss. By way of introduction, pain is a common complaint in the emergency department. NSAIDs are a common class of drugs that patients report having adverse reactions to. So we pose the question, can allergen testing be a solution to this problem? We hypothesized that ED patients with a reported NSAID allergy would be more likely to decline an offer of confirmatory allergen testing versus those patients with other reported drug allergies. Our study design is a prospective cross-sectional study of stable ED patients at a large tertiary community emergency department. We did complete a survey, including demographic and allergy history related questions. We included a description of the skin and oral allergen testing, and we assessed the willingness of the patient to have this testing done in the future. With regard to our statistical methods, a bivariate analysis was completed with categorical and continuous covariance analyzed by chi-square and t-test respectively. A multivariate logistical regression was conducted to control for confounding variables. Let's take a look at our results. Our mean age was 57 years old, 58% female, 60% Hispanic, income being 48% less than 20,000, high school graduation of 21%, and 27% having Medicaid insurance. 13% of the patients reported having an NSAID allergy, 27% an opioid allergy, and 34% penicillin. 77% of the patients with reported NSAID allergy indicated that this was diagnosed by a physician. Bivariate analyses demonstrated no significant difference in the willingness of patients to undergo future skin testing between those with reported NSAID versus non-NSAID allergies. There is no significant differences between the two groups with respect to willingness to undergo the skin and oral testing. The multivariate logistical regression demonstrated no significant associations between reporting an NSAID allergy and the various baseline patient characteristics. Patient insurance did demonstrate an increased willingness to undergo the skin testing, with private insurance having an odds ratio of 3.03, Medicaid at 2.49, and other insurance at 7.69, with all being statistically significant. Self-reported drug allergies are common in the emergency department. NSAID medications are the second most reported to cause adverse drug reactions, with bronchospasm, urticaria, and rhinosinusitis being the most common of these reactions. Study of greater than 1,000 patients completed in 2012 of those with reported allergies to beta-lactams found that only 16.4% had a true reaction. 62% of those were diagnosed with skin testing, while the rest had normal skin tests and required an oral test. A study of 325 children with suspected beta-lactam reactions had only 12% verified as true reactions, with the majority of those reactions being verified with skin testing and some delayed reactions requiring the oral test. In regards to testing for NSAID hypersensitivity, the oral test is the gold standard, with 4 studies, each with less than 200 subjects, demonstrating the percentage of true hypersensitivity occurring in patients from 21 to 28%. Why does this matter? We are in the midst of an opioid epidemic. Reporting an allergy to a non-narcotic medication has been demonstrated to have an odds ratio of 3.4 of being used by a drug-seeking patient in previous studies. Doctor shopping behavior also has an increased odds ratio of 3.1 for reporting non-narcotic drug allergies. Opioids from medical professionals can start drug addictions, as we've seen time and time again. There are a couple of limitations of this study, with them being a small sample size, as well as patient dishonesty could have a great effect on study results. In conclusion, within our study cohort, we did not find a difference in willingness to undergo future allergen skin testing between patients reporting NSAID versus other medication allergies. Here are my listed references. Thank you.